Hi, I'm Christie Morrison, and I'm one of the APP community network leaders here. So just joining you guys today to talk a little bit about non-invasive testings for evaluation of fatty liver disease with MASLD and MASH. I want to today start by explaining the fundamental differences between steatosis, or MASLD as we call it, and MASH. And so really the big difference there is in MASLD, we have the development of steatosis in the liver, whereas MASH has been the direct action of the steatosis causing inflammation and fibrosis and scarring in the liver. And unfortunately, we know that MASH can increase risk of development of cirrhosis over time related to that scarring. We stage that as stage 1 through 4 this time. We can definitely distinguish the difference between fatty liver disease alone, between fatty liver disease and MASH by using our non-invasive testing. And this is really great for a number of reasons, but it's because we don't have to put our patients through a liver biopsy to determine the severity of their fatty liver disease and to determine if there is already steatosis or fibrosis in the liver. And by not using an invasive test, our patients are going to be more willing to undergo these testing for us, which are usually just blood tests or a different type of ultrasound or imaging. And so they usually tolerate those really well. And it's going to give us a lot of information to really help guide their care and determine how aggressive we need to be with therapies and treatment for their fatty liver disease. So there's a couple of different non-invasive testings that we're going to talk about today. There's initially some serum-based non-invasive testing. So that means blood work that we can send the patients to do. Most of the time, just by getting their routine labs from their PCP, we've already got enough basic labs to do a FIB4 test. So what we need there is their AST, their ALT, and their platelets. And as long as they're between the ages of 35 and 65, we can really determine a score based on that FIB4 from those basic labs that will come from their PCP usually, because those are normally checked through just routine labs for every patient at least once a year. Once we get the FIB4 score back, we can determine if they're low risk, intermediate risk, or high risk based on that score, and then determine what the next best non-invasive testing will be. And we can use additional serum-based tests for that with something called the NAFLD fibrosis score, or we can use the enhanced liver fibrosis score. All of these, both the FIB4 and the NAFLD fibrosis score, can be calculated through a number of different medical calculation apps like MD-Calc, whereas the enhanced liver fibrosis score will really come directly from the lab. We can also use imaging-based non-invasive testing. Very commonly, we'll use something called Elastography with a FibroScan that you guys are probably familiar with from EchoSense, and then MRE, which is MRI elastography. Usually blood tests are a little bit more accessible for our patients, especially because all of them usually will come to us with at least the labs available from their PCP to calculate a FIB4 score. And if their FIB4 score is low risk, really no additional testing is needed at that point, as long as we have just maybe a basic ultrasound that shows steatosis in the liver and the patient doesn't have any other signs of advanced liver disease with things like thrombocytopenia or advanced physical exam findings consistent with some advanced liver disease. If they do have a moderate score or higher of their FIB4 score, then you would definitely want to get one of our other non-invasive testing with either serum or the imaging, which could be the enhanced liver fibrosis score or the FibroScan or MRE. I usually will determine which one of those tests is going to be the best for my patient just by talking with them. And it also kind of depends on where they're located. We have a lot of patients now that if they're in a smaller community, they may not have easy access to a FibroScan or even an MR or elastography at that point. So using one of our serum-based tests might be easier for them to get because they can do that usually at any of their just routine labs and sometimes even at their PCP's office. However, in a larger community, they may have access to the FibroScan. And even in communities where you don't have that available at a GI office, you might have a research group where that's available that they could go get that in determination if the patient qualifies for a research study related to MASH or MASLD. And it's just an ultrasound to start with for the FibroScan, that is. So it's not painful to the patient. The patient does need to be fasting to be able to get an accurate test so that the fibrosis score is not falsely elevated. But other than fasting, it's not an expensive test to undergo. It's not painful. They don't have to worry about claustrophobia with like an MRI elastography. Unfortunately, there are some limitations to the FibroScan. So sometimes if the patient has had an injury or scarring related to that area of the abdomen where we would be looking at the liver with the elastography, we may see falsely elevated fibrosis scores there, as sometimes it's hard to get accurate readings for the elastography as well if the patient has a significant amount of central obesity that can cause difficulties in just the ultrasound penetrating deep enough to evaluate that in elastography. In that case, an MR elastography might be a better score. That way it gets a better picture of the whole liver instead of just the right side that we would do with an ultrasound. Of course, with an MRI, that is a little bit more expensive, and some patients may not be able to tolerate that well, depending on whether or not they have claustrophobia. And again, when we're looking at the patient's community setting, is MR elastography available in their community setting? So they may need to travel farther away to a bigger city or a larger location where that's available. So when I'm looking at what testing I'm going to use for this patient, it really is a combination of multiple pictures, right? So I'm looking at their comorbidities, I'm looking at their liver function test and their history. And so usually, again, I'm starting with just that FIB4, which usually comes to me from their PCP office with their initial testing. And so if I'm able to look and see, do they have a low risk? Is their FIB4 less than 1.3? And I'm okay with just maybe some imaging to just ensure that there's nothing else anatomical going on in the liver. And that's usually just a basic ultrasound of the liver. Again, a lot of times the patients will come to us already with that once they had the initial elevation in liver enzymes. If it's a patient that has a lot of comorbidities, such as very uncontrolled type 2 diabetes, maybe they have some other cardiovascular risk factors, maybe they're obese, that might be somebody that I'm going to consider an additional testing on, especially if their FIB4 is in that intermediate risk range, which is anything from 1.3 to 2.67, or if they've got a higher risk FIB score of anything greater than 2.67, then I'm definitely going right into that ELF. Fortunately, if you don't have basic labs already from the PCP, sometimes you can order a FIB4 in the lab that will automatically reflex to an ELF2, so that saves the patient with an extra blood draw. So if you don't have an updated AST, ALT, or platelets, you can send the patient for FIB4 with a reflex to ELF, and that'll give you a little bit more information. Then depending on their ELF score is going to be depending on what we do next there. If they don't want to go back for another blood draw, or if they don't have a lab nearby them and I do have access to FibroScan, I will use FibroScan. Even if I do get an ELF first and it's in the moderate to severe risk, then I'm going to be sending them for a FibroScan to get a little bit better picture as well to ensure that they don't have advanced fibrosis. We do need to remember as well that patients with FT or F2 or F3 fibrosis may not exhibit any signs of fibrosis. They may not have thrombocytopenia. So we want to make sure we are really evaluating that fibrosis score to make sure that they're not already at risk for development of cirrhosis soon. So don't rely on symptoms to help guide that decision. Really, you want to rely on risk factors and your non-invasive testing with the FIB4 or ELF first. So what should APPs know about non-invasive testing to really stratify that fibrosis risk and guide your management pathway? Again, it's really making sure that you're aware of what are the scores, knowing how to differentiate what puts a patient in a mild, moderate, or severe risk. And that can be with your scoring systems, with your FIB4 or with your ELF score. So I would make sure that you have access to that Again, ELF score that we're going to be looking at, or the liver stiffness score with FibroScan, making sure that you are able to access those and use them appropriately in the right setting for your patient. Remember, there are some comorbidities that may help you choose one of those non-invasive testing more than another one. So if the patient has central obesity, maybe not using a FibroScan and using an ELF first or an MR elastography in that setting, remembering that hopefully most of the time the patients will come to you with a FIB-4 score already. But if they don't, that's something you can order within a reflex to an ALF that then can help you determine your next steps after that once you determine a potential risk for fibrosis in the liver. And then whatever one of those tests that was abnormal is what you want to use to guide you as you're monitoring after you implement your treatment plan for this patient. So if that is an ELF score or a FibroScan score, make sure that you're repeating that in 6 to 12 months later on to evaluate for improvement after you've implemented either lifestyle modifications and or medications such as Resmetirom. That's all I have today. So I thank you guys for joining me today to talk about non-invasive testing and the basics of non-invasive testing for our patients with fatty liver disease, and hopefully prevent the progression of fibrosis and MASH and later on cirrhosis in these patients.